gives me tremendous pleasure to introduce our first keynote speaker, Professor Vikram Patel, an old friend and a longtime colleague. Dr. Patel may be arguably the best known expert in global mental health and technology, possibly in the world today. Dr. Vikram Patel he is the Pershing Square Professor at the Blavatnik Institute at Harvard Medical School. Dr. Patel is also well recognized for his work in India. He serves as an adjunct professor at the Public Health Foundation of India. He's an honorary professor at the London School of Hygiene and Tropical Medicine, and is the co-founder of Sangat, an NGO from India that won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008, and the World Public Health Champion of India Award in 2016. Among other honors, Dr. Patel also co-chairs the Lancet Commission on Reimagining India's Health System. It's particularly wonderful, I think, to have Dr. Patel open up tips, because I think his topic that we will hear from about today is, it represents the evolution of digital health. Even in the 6 years that we've had tips, the field has evolved from being about early stage technologies and trials to starting to really make an impact on healthcare, not just within the US or in the American healthcare system, but truly globally, and particularly in low and middle income countries. What we will hear from Dr. Patel today is not so much about a cool technology or a cool tool or work being done in the lab, but how this is starting to really impact lives in parts of the world where access has been a great challenge. Vikram, thank you for joining us. Always a pleasure to hear you speak. We always learn something new. You have the floor.
Thank you so much. Thank you so much, Ipsit, and thank you so much for inviting me to open the tips this year. I've really enjoyed participating in the tips on a couple of occasions in the past, and it's a real pleasure to be able to present my own work here. It's especially important for me to emphasize that our work here is the utilization of digital technology is not so much, as you often hear, direct to the person with mental health problems, but in this case, to build the workforce to deliver mental health care. Because as we've known from the large body of evidence that has emerged in the last decade or so, it turns out that the actual uptake of self-help apps for mental health problems is actually relatively low in the population. It turns out that most people actually do want to see a skilled provider. And what I'm about to describe to you today is the rationale for actually building the workforce and the use of digital tools through our program called Empower that is seeking to massively and quickly build a workforce to scale up psychosocial interventions to reach the last mile. Now, let me first just start by saying a few words about psychosocial interventions. Of course, these are at the heart of almost all digital mental health interventions. Essentially, these are interventions that target either psychological mechanisms or the social mechanisms that underlie the vast majority of mental health problems, either explaining the onset of these problems and or their perpetuation and relapse. The evidence in support of psychosocial interventions for mental health problems is vast. In summary, they are the first line or the most effective intervention for a wide number of mental health conditions, such as, for example, PTSD, many of the anxiety disorders, and autism. Even when there is a choice between a pharmacological and a psychological intervention, as there is in the case of depression, where the two interventions in a head-to-head comparison show similar remission rates, we now know from the latest network meta-analysis published last year in World Psychiatry that when you consider the longer-term outcomes of recovery, that is low relapse rates, psychological treatments outperform pharmacological treatments. And in those mental health conditions where medication is clearly a superior intervention, for example, the psychoses and certain kinds of addictions, we know that the addition of a psychosocial intervention greatly enhances the effectiveness of pharmacotherapy. In a nutshell, then, there is scarcely a situation where a psychosocial intervention does not have a role in the clinical care of a mental health problem. So let us turn to the question of coverage. Given this very robust evidence, how many people who could benefit from psychosocial interventions actually receive them? And I'm going to give you a case study of depression, perhaps the most common mental health problem in the population. And I'm going to start with the US. The US, because of course, the US is the world's best resourced country. I mean, a lot of us who work in the US think we're not very well resourced, but if you look at the actual metrics of resources, the US is by far and away the best resourced country in terms of the number of mental health professionals per capita, the number of dollars spent on mental health care, and so on, as compared to any other country in the world. So one would expect a very high level of coverage for psychosocial interventions for depression. It turns out, however, that exactly the opposite is the case. Only about a quarter of people who actually seek care for depression, and mind you, this is only 50% of the population who are actually suffering from depression, only a quarter of those actually receive psychological treatments for depression, compared to 90% receiving medication. At the population level, this means that only about 10% of those living with a depressive episode in the US are receiving the intervention that is actually the most superior from a longer-term outcome perspective. And this is in spite of the fact also that patients, especially those who come from low-income and minority groups, overwhelmingly express preference, but ironically, are even less likely to receive these treatments. And for anyone who works in clinical care, it's obvious that when patients receive the treatment they prefer, they report greater satisfaction, higher rates of treatment completion, and superior clinical outcomes. In my mind, this really, and the situation globally, by the way, is even worse. In parts of the world that I have done much of my own work, such as, for example, in Sub-Saharan Africa and South Asia, there's virtually 0% coverage of these interventions in the global context. This is why I believe that when Tom Insel wrote about the crisis that he describes in the mental health in the US, he's really referring primarily to a crisis of care. That is to say that we have failed to deliver the interventions that we have known work in some instances for decades to the vast majority of people in the population who could benefit from them. And this is in spite of the fact that in the US, we spend more on mental health care than any other country in the world. Indeed, we might not even be aware of this, that we spend more on mental health care per capita than we even spend on most other medical conditions. In spite of these vast resources, the majority of people do not receive these interventions. A major reason for the failure to scale up psychosocial interventions is, of course, the lack, or rather the reliance on mental health professionals to deliver these interventions. As a result of the fact that the training of these interventions of these professionals is quite lengthy, quite expensive, and as a consequence, there aren't that many, especially in low resource contexts in the US and globally. There is therefore a major supply side barrier that limits the access to these interventions. Let me turn to the opportunity on how these barriers might be addressed. The story really begins about 10 years ago, just more than 10 years ago, when in fact Tom Insel was the director of the NIMH, and he invited Pamela Collins and myself to co-chair the scientific advisory board of a new NIMH initiative called the Grand Challenges in Global Mental Health. This initiative was intended to generate the research priorities, which, if addressed, could lead to a significant impact on the global burden of suffering due to mental health problems in a relatively short time span. We conducted a research priority setting exercise with nearly 400 experts drawn from around the world and across the full range of scientific disciplines concerned with mental health, from basic neuroscience all the way through to public health and implementation science, and including experts by experience. And we found that after going through 2 or 3 rounds of a narrowing down of these research priorities, that the leading research priorities published in this paper in Nature were all implementation science questions. They weren't questions about discovering the next molecule or the new neural circuit or new gene that could explain a mental health problem, but doing better with the knowledge we already had, bridging the no-do gap. Ever since the Grand Challenges were published, My estimate is that more than $1 billion of new research money has been funded, particularly low and middle income country institutions, mostly by the NIMH, but also by a range of other donors such as Grand Challenges Canada and the MRC in the United Kingdom and the Wellcome Trust. And thanks to this large research investment, today I can tell you with great confidence that we know how to deliver clinical and preventive psychosocial interventions in an affordable and acceptable way in any resource setting, thanks to a body of science that now exceeds 100 randomized controlled trials in more than 30 low and middle income countries. Indeed, there is also a large body of science that has emerged from the high income world. My colleague Daisy Singler led a systematic review of interventions for perinatal depression that use non-specialist providers that was published last year in JAMA Psychiatry. And her team was able to identify more than 40 randomized controlled trials, most of them conducted in North America. If you put together this whole body of evidence, we're talking of a body of evidence that probably exceeds 200 randomized controlled trials from across the world. This is perhaps the largest and most compelling body of implementation science in the mental health field in the last 2 decades. My own work has been predominantly in India, where I worked with the NGO Sangat, which has worked in using community resources for the delivery of evidence-based psychosocial interventions for a range of different goals and purposes and objectives. Here you can see the titles of some of our publications in journals like The Lancet, JAMA Psychiatry, and Lancet Psychiatry, demonstrating the array of different objectives of these kinds of interventions, from the prevention of mental health problems in adolescents to school-based interventions to promoting the recovery of people with chronic, enduring, disabling mental health conditions such as schizophrenia and autism. You can find a summary or synthesis of this body of evidence, including the description of the interventions in a number of systematic reviews, including examples such as these 2 from my own team that describe interventions that are targeted to people with psychotic conditions, as well as interventions, psychological treatments for individuals with mood, anxiety, and trauma-related conditions. What this body of evidence is doing is helping us redefine mental health care in many different ways. Firstly, by redefining what comprises a mental health intervention, we can now look beyond the complexity of multi-component psychological treatment packages that require many sessions, sometimes 20 to 30 sessions over extended periods of time, and involving many active ingredients that are very complex to learn and indeed practice, because this evidence has focused on brief interventions, typically comprising only 1 or 2 active ingredients, delivered over as few as a single session and up to 6 to 8 sessions. They usually also target the social mechanisms alongside the psychological mechanisms, and that is why I prefer to refer to them as psychosocial interventions. The interventions can be delivered wherever people are. Typically, in my own work, that is included in the homes of patients with mental health problems, but most often you see them delivered in primary care settings, in schools, and other community contexts. They can be delivered by anyone in the community who has a mandate, authority, or a desire to be involved in mental health care. In my own work, I've typically worked with community health workers, lay people, and peer support workers. Other kinds of non-specialist providers who have been involved include nurses, social workers, and people who work in the faith-based sector. And it's important for me to emphasize the how. Here we're talking not of a separate mental health care system, but an extension of the footprint of the existing mental health care system deep into the community to reach the last mile, reducing historic disparities in the access to quality care. This means that this form of intervention delivered in the community by frontline workers or non-specialist providers must be seen as a collaborative care model for ensuring that the community health workers are adequately supported, and patients who have more specialized needs can be seen by a behavioral or mental health provider. This evidence has been transforming mental health globally by influencing policies both at the global level. On the left-hand side, you can see the covers of 2 reports, the Mental Health Action Plan of the World Health Organization and the Disease Control Priorities publication on mental, neurological, and substance use disorders, both of which have embraced the notion of task sharing, that is to say, the delivery of evidence-based brief psychosocial interventions by frontline workers in community settings, but also the national level, such as, for example, the National Mental Health Policy of India, and more recently, just last year, in fact, the RAND Corporation, a report on how to transform the US mental health system. All of these reports are now calling for a scaling up of this rich implementation science by building the frontline workforce at the base of the community, of the pyramid of care, so that much larger proportions of people who could benefit from psychosocial interventions can now receive them. So the real big question is, how do we scale up? Now, if you consider how task sharing trials have taken place, typically the frontline workers are trained by experts in in-person workshops, and their supervision, support, and quality assurance is similarly done in person by experts. Of course, this is done to ensure the fidelity of the approach in the context of a randomized control trial. However, it is impossible to imagine how this approach could be utilized to scale up at the scale and at the speed that we so desperately need in these times. This is the context in which Empower was launched at Harvard Medical School 3 years ago. Empower seeks to use digital tools for the learning, mastering, and delivery of quality-assured psychosocial interventions. In a nutshell, what Empower is seeking to do is to empower anyone, anywhere, to master the delivery of evidence-based psychosocial interventions. Over the last 3 years, we have developed a number of principles and methods that actually underwrite the methodology that we use in Empower. In the first instance, it's the question of how do we select interventions. This is an extremely important, perhaps the single most important step in Empower, because as you know, there are many different competing interventions for mental health problems, often comprising extremely complex forms of psychotherapy. What we have decided is that we will only select those interventions that, number one, are evaluated at least in a couple of randomized controlled trials, but preferably in systematic reviews of interventions being delivered by non-specialist providers in real-world settings. This automatically rules out a large body of the psychosocial evidence literature where these interventions were delivered by specialist providers in highly stratified clinical settings. We will only then adopt interventions where there is a clearly defined active ingredient, for example, behavioral activation for depression or motivational enhancement for harmful drinking, and begin the work of constructing a competency-based curriculum by using a non-proprietary open access manual that was utilized in one of the randomized controlled trials that best aligns with this active ingredient. Our final selection of the active ingredient and the manual is approved by an international science council comprising psychological treatment experts with specific expertise in that particular mental health condition or intervention. With this in mind, we've identified a suite of interventions that can deliver mental health care based on a dimensional or staged approach, recognizing that one size does not fit all, and that interventions need to be delivered across the full severity spectrum of mental health problems. At the one end of the spectrum, where individuals are beginning to develop distressing symptoms but do not fall neatly into any diagnostic group, we are developing a single encounter intervention building on the rich literature of single session interventions that typically target social support and connectedness with the goal of prevention, and an audience that comprises pretty much any health professional in any context, but also includes lay people working in a variety of community sectors, such as, for example, the faith-based sector and CBOs. For individuals who have developed more sustained symptoms with functional impairment, who might now fit into one or the other of the broad diagnostic categories of mental health conditions, we are scaling up interventions that typically are multi-session, but they're still brief, on average between 6 to 10 sessions, where the target is the building of psychological skills. And the goal here is intervening as early as possible with the goal of preventing an acute crisis. The potential audience for these curricula are diverse groups of non-specialist health workers, such as, for example, nurses, social workers, and community health workers. Now, of course, it is important to recognize that some individuals will not respond even to these early interventions and may need an acute or inpatient stay managed by mental health specialists. The final stage then is the post-acute care with the goal of promoting recovery. This is, of course, especially relevant for people with enduring chronic mental health conditions such as chronic psychotic conditions, and the intervention is primarily focused at addressing social determinants, building coping skills, and supporting family members so that one can reduce relapse rates and optimize functional and social inclusion. The potential audience, of course, for this set of interventions is peer support workers. When you bridge together all of these different interventions, you can see that it covers almost the full range of population mental health needs and really supports on either side of an acute inpatient care episode before the episode occurs by preventing or reducing the risk of an episode through prevention, early intervention, but also after an episode by optimizing the odds of long-term recovery through the reduction of relapse and promoting social inclusion. The second important set of principles and method is the development of digital products and the deployment of digital tools for their delivery. And I'm going to speak a little bit more about that given the context of this conference. Over the last 2 or 3 years with NIMH support, we have developed a systematic methodology of developing a competency-based blueprint of our curriculum. As you remember, we start off with a particular manual and then we convert that into a competency-based blueprint, and then the scripting of these curricula. We develop methods for the design of competency assessments, both of knowledge using psychometrically validated questionnaires, but also of skills using structured role plays with ratings that are based upon the World Health Organization's EQUIP tools. And of course, we've developed all our digital content in a co-production mode with target audiences and with iterative reviews by experts from diverse stakeholder groups, including people with a lived experience. And the final set of principles and methods is that we implement these curricula through partners on the ground, such as hospital systems and governments, utilizing existing human resources, such as community health workers who are employed by those hospitals to ensure sustainability. As you'll see in the next slide, our model is that of an accompaniment model. We do not believe simply in providing training, but that the need for a naive learner is to be accompanied on a lifelong journey of learning, mastering, and delivering the intervention with the learning process supported initially by coaches and later on by peers. And soon in the coming months, we will launch an academy, which is an independent enterprise which will actively work with implementers to scale up the evidence-based products and tools that have been developed by my lab at Harvard Medical School. So what does this look like for the actual learner? I use the word accompaniment. This was a word that was coined by my late department chair, Paul Farmer, but he used that term specifically in the context of the accompaniment of a patient on the journey to recovery. We've adopted that term to describe the process through which Empower accompanies a learner on a lifelong journey of learning, delivering, and mastering psychosocial interventions. Imagine then a naive learner like a community health worker who has been authorized to learn how to deliver a psychosocial intervention for depression. The first thing that the learner will do is to complete a competency-based course, following which the person will complete a knowledge assessment of their competencies and reach the first milestone on their journey, being a competent learner. We all know that you can't learn any skill, such as a psychological treatment skill, simply by doing a course. Therefore, the next stage is case-based learning, practicing those skills with patients with the target mental health condition with expert supervision. After completion of a minimum amount of case-based learning, the individual now does a skills assessment of their competencies, and upon clearing that assessment, will now become credentialed provider. The person now enters the workforce, providing care along with other credential providers and participating in continuing measurement-based peer supervision, and over time will then become an expert provider or a coach who can then go on to support the next generation of learners. Across every step of this accompaniment process, we use different technologies. In the first step, the learning is done through the curriculum being delivered online on any one of the many learning management systems out there, such as, for example, Moodle or Cornerstone, building out the digital content on off-the-shelf programs such as Articulate. The competency assessments are delivered remotely. The knowledge assessments, of course, are just questionnaires, which is easy to understand how that will be delivered. But also, the skills assessments can be delivered remotely through either self-recorded or observed role plays, then rated with psychometrically validated measures. In partnership with the tech company Dimagi in Boston, we have designed and are testing now a bespoke digital app for measurement-based peer supervision and quality measurement simultaneously in the US and in India. And then finally, we use data science-driven evaluation of the digital data from training to competencies to quality of care. And ultimately, of course, we hope linking it to patient outcomes so that we can do a number of things, but most excitingly, to unpack the active ingredients that actually predict patient outcome. That is to say, which quality metrics predict patient outcomes so that subsequent training and supervision can actually increasingly focus on those those components, thereby in iterative cycles, increasing the overall effectiveness of the delivery system. Let me give you two examples really of how this is playing out in practice. And I want to start with the example of a brief behavioral activation treatment for depression that we designed for primary care in India. We evaluated it in a randomized control trial with 495 patients with severe depression. I need to stress that word, severe depression. We specifically only included individuals with PHQ-9 scores of 15 and above. The intervention was delivered by lay counselors in routine primary care settings. We completed the randomized control trial. I'll show you the results on the next slide. The results were replicated in a separate trial in Nepal. And as I speak, this particular intervention has been subsequently adapted for use with mothers who have perinatal depression and is being currently evaluated in multiple delivery formats in a 3-site randomized control trial in North America, funded by PCORI. This is really a summary of the results of the initial trial and also the long-term follow-up that is yet to be published, but a preprint is available online. The treatment consisted only of 6 sessions delivered over 6 to 8 weeks. And what you can see here at the primary endpoint of 3 months, that about 2/3 of patients had remitted. That is to say, patients who had started with a PHQ-9 score of 15 or more, 2/3 were now scoring less than 10. This was in contrast really to the much lower remission rates that you can see in the lighter blue dotted line here, a dashed line here, who were receiving enhanced usual care. 9 months later, at the 1-year follow-up, what you can see is a sustained remission rate. 2/3 still remained depression-free 12 months after they had been enrolled in the trial. As you can see, there's now a flattening of the curves for the enhanced usual care arm. Last year, a group of economists who were wanting to examine the impact of psychological treatments for depression on economic outcomes followed up this cohort of both the trial cohorts 5 years after their entry into the trial. And what you can see here is that 5 years later, those gains are still sustained. 2/3 of the patients remain depression-free. This, in my mind, is an astonishing result for people with the most severe end of depression, treated with just 6 sessions with behavioral activation, that they remain depression-free 5 years later. Equally, though, you could argue that the counterfactual is that 1/3 remain severely depressed, and clearly that shows that one size does not fit all. But 2/3 of patients could be managed effectively by people working at the front line who have no prior mental health specialist training. With NIMH support, we digitized the curriculum for learning this intervention, which we call the Healthy Activity Program, and ran a non-inferiority trial in which we compared two forms of digital training completely self-guided and digital training supported by a coach, compared with expert-led in-person workshop-based gold standard arm, the face-to-face arm. What you can see here, there was an increase in competencies on a psychometrically valid scale for all the conditions, and that there was no statistically different. There was an improvement in all the three arms, as you can see in competencies, but there was no statistically significant difference in the change in competency scores between training conditions, a result that we have now replicated in a separate trial for a problem-solving intervention for adolescents that I'll talk about in a moment. The digital content was built out on a Moodle platform. Subsequently, led by Daisy Singler from the University of Toronto, we have been designing and testing a measurement-based supervision app. This is called the Peers Project, in which once a provider has completed the online training, he or she now gets access to the supervision app on which they can do multiple things. They can maintain patient records, rating the person's mood in every session. They can use this particular app to audio record sessions, to track PHQ-9 scores over time. But most importantly, that these audio recorded sessions can then be allocated to peer groups for listening and rating using a psychometrically valid questionnaire that is specific to that particular treatment. In this case, for example, the quality assessment for the Healthy Activity Program for sessions of the Healthy Activity Program for depression. And these can then be viewed in a graphical form, but also provide a summary of the quality ratings of sessions delivered by a particular provider, rated by their peers and/or an expert. As I speak, this digital platform is being used to scale up the behavioral activation treatment in central India, in the rural districts of Madhya Pradesh, a state in the heart of the country. And here on the left-hand side, you can see an image of a training session with frontline workers who are learning how to use the Peers app. And on the right-hand side, you can see one of those trained workers now delivering a session of the treatment to a woman in her home. I arrived at Harvard Medical School in 2017 and quickly realized that there were very large unmet needs for care for depression, indeed all mental health problems in this country, which somewhat surprised me, given the fact that there was such a great excess of resources in the country. Of course, we now know that there are many reasons that in spite of these large resources, there is so much unmet need. I had the good fortune of forging an alliance with the Meadows Mental Health Policy Institute led by Andy Keller and the American Psychological Association led by Arthur Evans, who began a conversation with me about how we could bring this innovation of task sharing to community health workers or other frontline workers to deliver psychosocial interventions in community settings to the US. And I told them about the use of digital tools, and they were very excited. So we began the journey of launching Empower in the US, beginning by adapting the curricula for the delivery of depression treatment that comprises two curricula, a foundational skills, which is really the non-specific skills for any psychological intervention for adults, and then the behavioral activation intervention for depression that was developed in partnership with the APA and ultimately signed off by APA experts. And here you can see a screenshot of the digital content that we are making available on the Cornerstone platform. Last year, in the midst of the pandemic, a group of Texan philanthropists put out a call for bids called the Lone Star Prize to transform the lives of Texans. Led by the Meadows Mental Health Policy Institute, we put in our bid to scale up depression care in underserved counties in Texas, which included a collaborative care delivery model with frontline workers or community health workers delivering BA treatment to depression as the first responder care. We were delighted that we won the Lone Star Prize, and the Lone Star Depression Challenge over the next 3 to 4 years will be training hundreds of community health workers to deliver the brief behavioral activation treatment and to complete supervision and credentialing using the various digital tools that I described a little earlier. This may well be the first time that community health workers are scaling up depression care in the community in the US. Another example of another intervention that we are developing, this is also at the distress part of the staging continuum. If you remember, there were three stages: the distress, the disorder, and psychosocial disability. So here we're talking about disorders, depression, and in this case, adolescent mood and anxiety disorders. We designed a very brief problem-solving intervention comprising only 4 sessions to be delivered by school counselors in routine school settings and demonstrated the effectiveness both in the short and the longer term. We've just completed a training trial, again, very similar to the one that we did for depression, but here we were only comparing training in 2 digital modes with and without coaching, demonstrating most importantly the high levels of acceptability and engagement and pretty good competency gains when an individual completes the trial, the online curriculum. But of course, just to again emphasize that this is only the first stage in the journey to becoming a credential provider. A few months ago, the Manton Foundation awarded us a gift that will now allow us to do similar work in the US in a program that is led by John Weiss and includes collaborations with the Children's Hospital of Philadelphia and psychologists and psychiatrists in the Children's Hospital, Tammy Benton and Jamie Young. We will be building out a curriculum for school counselors as well as other frontline staff who work with children and adolescents with mental health problems. And again, this is a partnership with professional organizations, including the APA. Many of you will know that John Weiss is one of the pioneers in adolescent psychological treatments, and he has developed this model of multi-component psychological treatments based on these 5 principles of psychological treatments with procedures for each of those principles. And as I speak, we are distilling which of these are likely to make it into the main curriculum for the frontline providers. Our goal is to really see this intervention as the first step in a stepped care approach for adolescents with mood and anxiety problems. In closing then, I think what I really want to leave you with is this message that the opportunity, we have a historic opportunity really. The historic opportunity has really been presented by the COVID pandemic when mental health has been propelled into the spotlight in global and national policy. The real historic opportunity for us here is to close the no-do gap. We've known for a long time that psychosocial interventions can be transformative for people with mental health problems, but we've always been limited in our ability to scale them up because of the shortage of the workforce. We now know how we can build psychosocial interventions in the community through using community workforce. And what I hope I've been able to show you is how we can deploy digital tools and products to rapidly enable the frontline workforce to learn, master, deliver, and evaluate these interventions. Even before the pandemic, the mental health care system was completely unable to meet the needs of people in the population. With the rising demand of the COVID, thanks to the pandemic, business as usual will be even more inadequate. We will need to radically reimagine how we deliver mental health care. We have the science that demonstrates how we can do that. And digital technologies offer us a unique historic opportunity to scale up these interventions. For those of you who would like more information on Empower, I'm delighted to say that a much more detailed session will be led by some of my colleagues, including my tech partners in Dimagi at Friday in the tips at a 10:30 a.m. session. You can also visit our website. You can contact the Empower program manager in my lab, Natalie Carmio, or you could read the article that we published in the American Psychiatric Association journal Focus a few months ago. Thank you very much. And I think there's still some time for questions. I'm happy to take them now.
Thank you so much, Vikram. That was a wonderful synopsis of the broad swath of your work spanning India and impressively now the United States as well. To our attendees, please use the question and answer box to submit any questions. We have a couple coming in. While we wait for some more, Vikram, I'll start with one quick one. In some ways, depression sets the floor for scalable mental health treatments. It's the most widespread and the most frequent through certain lenses occurring mental health diagnosis worldwide. But where do you see the ceiling in terms of psychopathology to around where approaches like this can be applied? Do you think it can be effective for serious mental illnesses like bipolar disorder or schizophrenia, or do you see it more for depression or anxiety or treatments that can be treated effectively with non-pharm approaches?
So,
I guess what I'm asking is, like, what do we do with patients who are fewer in number but higher in terms of care consumption?
So honestly, Ipsit, I don't think one can ever have a one size fits all. Even for people with depression, let's be honest, as I showed you in my own work, a third of patients remain severely depressed in spite of the psychological treatment. They will need something different, whether it's medication or ECT or TMS. What we must move away from is a one size fits all protocolized approach, a cookie cutter approach. What we must move towards is a step care approach or a stage approach, which simply recognizes that in a step care model, everyone gets a low intensity intervention first, because we don't unfortunately know at this stage of science who might benefit better from what particular intervention. Precision medicine is, of course, the holy grail of that kind of approach. But honestly, we don't have any definitive signals about which patient with depression would do better with which intervention. We just don't know. So for now, the step care approach is the most logical and parsimonious approach. Everyone gets a single session. We know that a single session itself, just by itself, a carefully designed single session intervention with a 2-week follow-up could probably be sufficient for a significant proportion of patients. If it isn't, you can then trigger a 6-session treatment. And if that isn't good enough, you can then actually refer for a more specialized care. What this allows the specialist to do is to work at the top of their license. It allows a specialist to actually care for those individuals who have exactly the kind of enduring, complex mental health problems that you're referring to, for which task sharing is inadequate. It is not to deal with those problems. It is to deal with the bread and butter, the everyday common mental health problems that you encounter in the population. To the issue of more enduring mental health problems, there's no question pharmacotherapy is critical. For that, you do need a prescriber. But I think we all know, those of us who work with patients with psychosis, that you wish that after the patient left your clinic with a prescription for risperidone, that there was going to be a community health worker who would work with them and their families to promote inclusion, to connect and navigate with social welfare opportunities for befriending. I mean, we all recognize that. Wouldn't it make for a comprehensive package of care that when the person leaves the clinic, you know that there is somebody else who you are you're in contact with, who will support that individual in their recovery goals in the community. So it's not either or. In that instance, it's an adjunct to the prescriber intervention, which I believe all the science shows will improve long-term outcomes in terms of reducing relapse rates.
Right. Thank you for that. I think this idea that you can use technology to train a person who may not be a specialist to develop mental health competence and then augment more traditional care, which in turn can be supported by other tools like apps. I think we're seeing the early signs of a true hybrid, not model of care, but a hybrid ecosystem of care that's multi-tiered. And I think what's so impressive about what you said is the demonstration, which is there's not a lot of evidence like this that shows that it's not restricted to high resource countries, that this can be done anywhere provided you can adapt it. Another question that just came in is that numerous large studies in depression have shown good short-term response rates to 8 to 12 session CBT, but that there's a high likelihood of relapse in these situations. Do you think that your results around behavioral activations effects being sustained is a more superior approach? And if so, what about behavioral activation do you see as being more effective in preventing relapse than CBT?
So, behavioral activation is part of the CBT family, and it's interesting. I don't know the actually very few really long-term follow-ups. There aren't that many, and I'd be very keen to sort of the person who put that question. Please do afterwards, do share that literature with me that you were referring to. The long-term studies that I do know of CBT, in fact, do show some reasonably good outcome, results, but let me turn to the question of BA and why it might paradoxically be better than the full Monty of everything else that goes with BA. Cognitive behavior therapy will also include the cognitive component, of course. I think it's because BA is very easy to learn. And ultimately, if you have to imagine, what do psychological treatments really do? What they're really doing is they're targeting your ability to actually cope with difficult emotional inner experiences, but also with experiences that are happening in your social world. Say, for example, problem solving is a good example of that. Now, if it is a case that sustaining this, the effects of the intervention requires you to master these skills, so that when you're faced with difficult or stressful situations in the future, you're able to deploy them, in a natural way. It is plausible that if you're taught one thing, and you master that and you do it really well and you know when to deploy it, that you're likely to use it much more with greater fidelity in the future than if you're taught 5 things and then you've got to try and figure out, or you have to try and master all of them. This is just a speculation. If it is indeed the case that CBT has less impressive long-term outcomes than just BA, I would guess that might be a reason, but honestly, I don't know if that's really true. One thing I will tell you is that in the trials that have done head-to-head comparisons of CBT and BA, like the big COBRA trial that was published a few years ago from Britain, there is no difference in remission rates and also at 12-month recovery rates. So even if you look at the treatment guidelines these days, like the NICE guidelines in Britain, behavioral activation is now recommended as the first-line psychological treatment for depression, not the full CBT. Because in fact, even empirical head-to-head comparisons show that they're equivalent in effectiveness.
So interesting. And add on to that.
Sometimes, sorry, I was going to say, sometimes less is more. I do think that one of the reasons why psychological treatments may not have been scaled up is because we have actually added more and more and more to these treatments and made them actually pretty complex, requiring a significant amount of training and supervision to first learn how to do the treatment. But then you can imagine, if you're receiving the treatment, the number of tasks that you have to learn, number of skills you've got to master. I think this might be a real opportunity to, as it were, strip down these complex treatments into really the heart of the treatment, of the active ingredient. And, there's been a number of very important, scholars who worked in this area. John Weitz, my colleague at Harvard, Bruce Jorpeter, with his model of distillation, an elements-based approach to psychological treatment. So, there's a rich history in psychological science of stripping down these complex interventions to their active ingredients.
So interesting. And I think it gets to the heart of scalability, which is it's probably going to be unwieldy to scale tertiary level care. I think your point about simplification is well taken. Another question that was an add-on was, does the collaborative community care model extend to help people who are depressed but did not respond to the initial treatment? I guess, in other words, in this model, what of those 40% that stayed depressed throughout, how does this model help them?
Well, that's where the collaborative care comes in. So, collaborative care requires dynamic, continuing monitoring. So this is inbuilt measurement-based care is part of collaborative care. You are measuring the severity of symptoms and functional impairment at every session, or at least at certain predefined, points in the trajectory of the treatment. And that there are predefined rules that if a certain treatment goal has not been met, the person has to be referred and seen by a mental health specialist. So that's what collaborative care is. Collaborative care, by definition, incorporates a team-based approach with a mental health specialist typically acting as the mentor of the team, not only supporting and supervising the team, but also providing clinical care for those individuals who are not responding in the step care approach to the first or the second steps of care. There's also another way in which specialists can be involved, which is in certain health systems or certain protocols, you can red flag patients to be immediately seen by a specialist. So in many healthcare systems, if a person is actively suicidal or has just had, made a suicide attempt, that individual may not only be seen by the frontline worker, they may be seen jointly by the specialist and the frontline worker. So there are multiple models, and those are models of care that can be tailored to the context that you're in, because obviously all of this implies that there is a mental health specialist, which is not the case in very large sections of the world's population.
Thank you. I'll invite our participants to submit further questions through the Q&A box at the bottom of your screen. Another question we had was, do you see different challenges in implementing this in different countries? I mean, the low and middle income countries are not a monolith, and there's unique region and geographical and political processes that get in the way. Have you had to deal with obstacles or challenges around getting buy-in from governments or local administrations or authorities? And how does that regulatory and scientific/clinical interaction play out? Any sort of practical lessons learned that may be helpful to our audience?
Yeah, each place is different. Ipsit, as you can imagine, because regulatory authorities are obviously by definition different in different places, and professional guilds are also important to recognize also as potential facilitators, but also potentially at times could be obstacles. So I think what's changed in the last 10 years, Ipsit, 10 years ago there was very little evidence, and today as I said, we have more than 100 randomized controlled trials. So I think what's changed is that body of science, and I think it's a really important point for me to stress. Without this science, I don't think we would be doing what we're doing now, because there would be tremendous pushback. It's very hard to push back such a large body of science. It's just not, all the questions, does it work? Is it safe? Is it acceptable? Those questions have been answered repeatedly in multiple contexts. So now, there is a lot more open-mindedness in every single of these different sectors, the regulatory authorities and so on. And in fact, if you look at in the US, for example, if you look at all the major announcement that governments have made, from the Biden administration to states like California, and you look at the big mental health, goals, the number one is building the workforce. And that's a euphemism actually for building the community workforce. Of course, in other parts of the world, like in Africa and Asia, there are very few mental health specialists. So community health workers have been historically used for the full range of healthcare goals, including NCD care, palliative care, maternal and child care. So adding mental health care is not a significant new thing. Frontline workers have been used for so many other goals. So there's a difference from context to context. Finally, I think the single most important question is going to be, there are two questions really. How do you build a collaborative care model? Because you cannot see community health workers as a standalone. I want to stress this repeatedly, not only because it's not good for patient care, but also because it's not good for the community health worker. I don't think we should be dumping mental health care on community health workers. I think we should be arguing for a team-based approach of a specialist working as with a team of frontline workers. And the second is the financing. In many countries, community health workers are salaried, so that's a good thing. But in many countries, like here in the US, they're actually they're reimbursed, and so you have to figure out how mental health work will now be adequately compensated for frontline workers who receive adequate compensation for that. And it's work in progress. We're learning as we work in Texas, as we work in India, and as I hope in the coming months and years, we'll be working with many other contexts and implementing organizations. In every place, there will be some particularity of that place that we will have to work within.
A couple more questions just came in, and we might have time for these two. What are your thoughts, Vikram, on how your approach can be adapted to serve displaced populations like refugees who are inherently disconnected from local communities, and they might actually be living in places that are hostile?
Well, for me, that's a community too. Wherever communities, wherever you are. I agree the community in that context may be more as it were, may not have historical connections and ties, but it is still a community of people. And one thing about refugee communities is there's often a kind of a psychosocial response, a humanitarian response with humanitarian workers who are engaged with a variety of humanitarian acts. And so incorporating this kind of training, but I would say the training should be really very much the kind of at the distress end and not at the disorder end, because there's a high level of psychological distress in these kinds of communities, not necessarily evolving into significant clinical problems unless, of course, there is no care being provided. So providing basic psychosocial interventions would be, in my mind, the focus. But there's no reason why this kind of model, in fact, if anything, this is even more relevant to context, because these tools can be made available to humanitarian workers, at an instant, because they are all digital.
In India, there's this general perception, inaccurate as it were, that psychological treatments don't work. And there's sort of this primacy given to pharmacotherapy. Did you come across this, and did it influence receptivity on part of the people the workers interacted with? And how was that overcome?
So it's interesting. I thought the same, so whoever's asking that question, I had exactly the same view. I'd been brought up to think that people like pills. Actually, it's very interesting. My first part of my work in India and in Zimbabwe was with medication. And the first thing I noticed was the very low adherence with medication. It was fabulously difficult to get people to take antidepressants for anything more than 2 or 3 weeks. And if they did, they would take it in subtherapeutic doses, because, mostly people use tricyclics, where you have to build up the dose to the maximum or the therapeutic dose. People never got to the therapeutic dose, and that includes the doctors. The primary care practitioners would not wish to prescribe more than 25 milligrams of say, amitriptyline. So actually, the antidepressant medication was a placebo medication. No one actually either took it for the right time or took it in the right dose. When we did psychotherapy, first of all, the dose is just 6 sessions. That's a pretty short dose, as opposed to a tablet or 3 or 4 tablets every day for 12 months. It's much less of a burden on the person to actually do 6 sessions. The second is that these sessions can be delivered at home, which means that there is no traveling to the clinic to even pick up the prescription. And of course, because it's being provided by a community health worker, there is no cost. You're not purchasing. Medication is not free in India. You have to purchase, so even the doctor may be free, but because it's a public system, but the medication still has to be purchased. So actually, it's cheaper in time, cheaper in actual direct costs, and it's more convenient. And we found very high adherence rates. 2/3 of people completed a 6-session treatment, which is much more than the proportion of people who take antidepressants in the right dose for 3 months. So that was our real world experience.
That's remarkable. Vikram, thank you so much. We're about out of time for this session. We look forward to hearing more about the Empower work from your colleagues on Friday morning. As always, it's a pleasure talking to you. And like I said, we always learn every time we hear you speak. For the rest of our attendees, we will be diving right into our next session. For that, we ask that you disconnect from this particular Zoom link and access the next session through the conference platform. Vikram, thank you so much.
Thank you, Ipsit. Thank you so very much. Thank you all. Bye-bye.
Bye.